Thank you, Shalander. Let me share. Can you hear me okay? And see my slides okay?
Yes, very
Okay.
well. Thank you.
So thank you for that introduction, and thank you to the organizers for allowing me to present updates in small cell lung cancer. I'm going to bend the rules a little bit and not only show you what was presented at ASCO, but open it up a little bit because there has been a lot of some updates that were not presented at ASCO that have changed how we treat small cell lung cancer in 2020. This is my updated disclosures, and the more important one is that this is not my home. This is a virtual background, but you can book it on Airbnb. It's in the mountains in Peru. So for small cell lung cancer, really, as we all know, the treatment had not changed for decades. I'm responsible to teach our fellows about small cell, and before 2018, I had not changed my slides for a long time because really nothing changed. It was not until 2015 that we started to understand that immunotherapy was found to be effective. Initially, this was after for patients that were treated with that had progressive disease after doublet chemotherapy, doublet platinum chemotherapy. These are two curves from a phase 1 study that was published in Lancet Oncology of 2016. Over here on the left, you can see with treatment on nivolumab alone, and on the right, treatment with nivo-ipi. And what you can see here in this spider plot are that immunotherapy led to some responses, and some of which were long lasting. So this led to the endorsement by the NCCN guidelines of the treatment with nivo-ipi if for patients that had progressed on platinum doublets. We later found the results of these two trials. On the left here was a study published in the New England Journal of Medicine, where patients were randomized to the standard treatment of carboplatin and etoposide without anything, or with the addition of atezolizumab. And this was the phase 3 clinical trial, the first phase 3 clinical trial that showed an overall survival advantage in many years. These results were later supported by the Caspian study, which was a very similar study that randomized patients between EP alone and durvalumab, and EP plus durvalumab, and again showed a very similar overall survival benefit. The difference between those two trials is that the Caspian study, the one from durvalumab, allow patients to be treated with cisplatin, in contrast to the Empower study that where carboplatin was the only one used, and this allowed for 6 cycles of chemotherapy, while this was limited to 4 cycles of chemotherapy. What we saw at ASCO was 2 or actually 3 updates in this same topic. One was this presentation by Tiziana Leal, who presented this Ecock study, which was a phase 2 study that randomized patients between cisplatin or carboplatin and etoposide, which was again the standard of care at that time, every 3 weeks for 4 cycles, versus the same regimen now with the addition of nivolumab, and then nivolumab maintenance after 4 cycles every 2 weeks after 2 years. This was a smaller phase 2 study that despite it being smaller and only having 160 patients, showed an overall survival advantage with the same magnitude as the Empower study and the Caspian study. We also learned from the Keynote 604 study. This is again a very similar study. The main difference is, as all keynotes, this study had pembrolizumab. Similar to the Empower study, there was a placebo-controlled study. It was a double-blind study. Here, patients or providers could use cisplatin if they wanted to in whatever arm, and similar to both studies, patients were allowed to continue on maintenance pembrolizumab. The key difference in how they designed this study is that in the prior 3 studies that I showed you, the primary endpoint was overall survival. Here, they designed the study differently. They were they started the trial later than the other two, so they wanted to see if PFS was also a primary. They decided with PFS as a primary endpoint, I guess, because they wanted to see more rapid results. So they decided for PFS as a primary endpoint with a co-primary endpoint on overall survival. And that will be important here in a second, because when they looked at the PFS endpoint, it was clearly better for the Pembro arm. And I don't know enough about statistics to tell you exactly what happened here, but because they had seen PFS as a co-primary endpoint, then the p-value for it to be a positive study had to be less. So the prior their statistical rules will need to be a p of less than one, I think 0.01, to be that a positive study. So officially, although they saw a benefit in of the same magnitude in overall survival, this was a negative study because they did not reach that p-value to have it be statistically significant. We also saw a update on the Caspian study. Again, this was a study that was a non-placebo control, and this had actually 3 arms. One arm was the chemotherapy alone for up to 6 cycles. Then there was the durvalumab arm, which was the same treatment with the addition of durvalumab. But there was the third arm that was the same chemotherapy plus durvalumab and the CTLA-4 antagonist tremelimumab. This data had not been presented yet. What has been presented is only this 2-arm. Again, this is another one that you need to learn to know a lot about statistics. But for this to be a positive study, the p-value had to be less than 0.0418 for this arm to be significant. And what they saw was that numerically there was a possible advantage for those patients that were treated with D plus T, but the p-value was 0.451, not reaching that 0.418. So therefore, officially, this arm was no different than chemotherapy. We also saw an update of the durvalumab arm. If you remember the slide that I showed you, where that was published in Lancet Oncology, that was a very early on slide, and therefore there was a lot of censoring. Here, what was presented has a longer follow-up, and we see that has a ratio of around 0.75 has been maintained. And we have an overall survival at 2 years of 22% in those treated with the addition of durvalumab, compared to 14% with those treated without immunotherapy in first line. This is a curve that shows you the all arms. It doesn't add much to what we already knew. This is from I found that if you have access to the ASCO presentations, the discussion led by Dr. Wonikoko from Emory was a very good one. And what he did was present all data from all these 4 studies in 3 arms. In 5 arms. Here you see that the studies are actually quite comparable in terms of a hazard ratio when you add immunotherapy to chemotherapy. All have a very similar hazard ratio. They also have a very similar median overall survival, and more importantly, a very similar overall survival at 1 year and at 2 years. So this just shows, I think it's important data to show that that immunotherapy is, the addition of immunotherapy is the new standard. Interestingly, this are the curves of all those studies. In a few things that are interesting are that the curves do not really separate until chemotherapy is done. So they separate late. This is in contrast to non-small cell lung cancer, where you see an early separation of the curves. We don't know why that is. We know that that this is not maintenance, and I'll show you that in a little bit. But we don't know why curves do not separate until late. An update that was presented this year at ESMO by Dr. Liu from Washington, D.C. is can we know who are the patients that benefit most from this? And this was an analysis from the Empower study, and there was really no in multivariate analysis no characteristic that that will tell us who that patient is. What we saw was the expected, that if you had a lower ECOG performance status, you had better results. That if you have less burden of disease, you have better results, and if your LDH was lower, you have better results, which again are expected. So my take points from immunotherapy in this setting is that there's remarkable similarities across all these 4 trials. That clearly chemoimmunotherapy is the new standard, with atezolizumab and durvalumab that are approved, and we don't know at this point in time that one is better than the others. That there's no biomarkers that are available. That curves do not separate until later. However, we know that maintenance is not the issue, and I'll tell you a little bit more about in a few minutes. And that starting immunotherapy, because of this reason, it reassures me that starting immunotherapy at the first cycle is likely okay. And this is important in this disease because many times these patients present to the hospital and need treatment right away. And durvalumab is not approved, or atezolizumab is not approved to be given in the hospital, or you need more time to get this insurance approval, and just starting with chemotherapy during the first cycle and then adding the atezolizumab or durvalumab in the first cycle is likely okay. What also a key endpoint for this is the CTLA-4 have a role. Again, the first, if you remember, one of the first slides I showed you was that Ipi and Nivo appear to have a role in this disease. However, like I showed you in the Caspian study, tremelimumab did not appear to play a role, and this is also was shown in other conferences, not an ASCO. This is a study that was published in Journal of Thoracic Oncology in 2019, where patients were randomized to nivolumab or nivo-ipi after maintenance, after after first-line therapy. And in this study, the addition of nivo-ipi did not show a difference. This is similar to a study that was presented in the European Lung Cancer Conference, which is Checkmate 451, where patients were randomized to nivolumab and ipi after chemotherapy and after 4 cycles of chemotherapy, and this did not show any difference. Why that is, we don't know. This is a different regimen of nivo-ipi compared to that Dr. West showed you before, where the nivo is dosed at 3 milligrams per kilogram, and ipi is dosed every 6 weeks. And this one is a higher dose of ipi at 3 milligrams per kilogram and a lower dose of nivo at 1 milligram per kilogram. So is that why the difference? We don't know, but it's something that that is interesting. But what we know now is that in patients who have had prior exposure to, what we know now is that patients with small cell lung cancer, nivo-ipi is no difference than nivolumab, and therefore that has been eliminated from the NCCN guidelines as a possible treatment option. So that brings me to what to do in second-line treatment for this disease. We know that for patients that have received chemotherapy as first-line, chemoimmunotherapy as first-line treatment, the addition of immunotherapy does not play a role because they're receiving during first line. We know that if the if patients progress in more than 6 months of receiving platinum chemotherapy, Reintroduction of platinum chemotherapy is probably the best regimen if they have the performance status. Whether patients present with relapse between 3 and 6 months is a little bit of a gray area. And I'm going to show you here the curves that from a study that was published very recently in Lancet Oncology. This is a French study that randomized patients between topotecan, which is, as you all know, was the best, the only second-line treatment that was approved, and patients were randomized to topotecan versus reintroduction of doublet chemotherapy. And what you see here in Group A is that progression-free survival was better for those patients that received combination chemotherapy. This did not translate into an overall survival benefit, but if you read the paper, interestingly, 40% of patients receive combination chemotherapy as third-line treatment. So that might explain why this was not translated into an overall survival benefit. So again, this is if patients present within 3 and 6 months of relapse progression after chemotherapy, I believe that if patients have maintained their performance status, reintroducing chemotherapy is a good option. Other options for second-line chemotherapy are topotecan, irinotecan, paclitaxel, gemcitabine, and the new kid on the block, which is lubrinectine. So I'm going to spend a few minutes talking about that. So lubrinectine, every article I read about lubrinectine has a different mechanism of action. So that I think is because nobody really knows how it works. We know that it's an inhibitor of active transcription, that it also causes DNA break accumulation and increases apoptosis and maybe some modulation of the tumor microenvironment. How this agent has been studied has been very interesting. It first was studied in phase 1 studies, and there was a subset of patients with small cell lung cancer that had activity. There was also data on preclinical data that was maybe a synergy with doxorubicin. So there was a phase 1 study of that combination in patients that had progressed through immunotherapy, and that showed an overall response rate of 50% in 24 patients. So that led to the Atlantis study. The Atlantis study is a phase 3 study where patients that progressed on chemotherapy, on doublet chemotherapy, are randomized to the combination of doxorubicin versus lubrinectine versus dealer's choice of topotecan at the standard dosing or a CAV combination, which is a common second-line treatment in Europe, and then their follow-up for an endpoint on overall survival. At the same time that this was this study was going on, they also did a phase 2 study of lubrinectine alone, where 105 patients were enrolled. Patients have to have no progression in the CNS. 40 patients had less than 90 days of chemotherapy-free interval, and 60% had more than 60 days of chemotherapy-free interval. And most of, except 7 patients, were treated after first-line therapy. Here, the overall response rate was 35%, which is remarkable for this disease. In the biggest phase 3 studies of topotecan, the overall response rate is close to 10%. And the progression-free survival was 3.5 months, and the overall survival was 9.3 months. And this study led to the FDA approval of this drug for patients that progressed on immunotherapy. So now is something that is readily available. This study was also published in Lancet Oncology this year, and this is a swimmer's plot that shows you that there's some patients that have a pretty significant overall survival or disease-free survival in treatment with lubrinectine. Lubrinexine is a chemotherapy. The most expected side effects that you see are obviously neutropenia. I can't remember the value exactly, but around 40% of patients in the trial had to have growth factor support. You also see nausea and fatigue as the most common side effects. So again, this is an agent that is all today approved in the U.S. For treatment of patients that have progressed on chemotherapy. How I find it's going to be challenging is we know that the Atlantis study that I showed you about has already completed accrual and it's likely to be presented later this year. But how we're going to interpret this study is challenging because again, this was a combination study with Lurbi and doxorubicin. So what will happen if this is a positive study? Will that mean that we should use this combination, or should we just stick with Lurbi alone? What happens if this study is negative? Does that mean that that Lurbi alone should not be used? I don't know how we will interpret that. And again, this is something that that we'll likely discuss next year. And this is just to show you what is in the works for this disease. To conclude, I'm going to present you also a study that was presented at ESMO because regarding limited stage setting. So is there any changes in limited stage in the treatment of limited stage disease? The current standard is cisplatin and etoposide long radiation. There's a lot of debate about whether to use daily versus BID radiation. I'm not going to go into that debate because that's a radiation oncology question that that again, if you have two radiation oncologists, you can be here all day discussing that issue. The main question is it the same thing as in non-small cell lung cancer, where we know immunotherapy works in this setting? And what was presented in the ESMO a few weeks ago was the Stimulate trial, which was a study where patients were randomized to receive a combination of Nivo and Ipi at the higher dose of Ipi of 3 milligrams per kilogram and Nivo at 1 milligram per kilogram. Again, different than what Dr. West presented for the 9LA study. So patients were randomized after chemoradiation to the Nivo-Ipi versus observation. And as you can see here in this overall survival curve, this did not lead to an overall survival advantage. This was a phase 2 study, so a limited number of patients. But again, this was a negative study. So that I've seen in practice that some patients have been, or some providers have been using atezolizumab or durvalumab after chemo rats in limited stage disease, and I think that that should only be done in the context of clinical trial, because this is a different disease, and we do not know if this pattern of how we treat non-small cell lung cancer applies for small cell lung cancer. We know that that trials with durvalumab and atezolizumab in this setting are ongoing, where patients were randomized to after chemoradiation to one of these agents. And again, like I said before, this should only be done in the context of a clinical trial, in my opinion. So as for conclusion, after several decades of no significant advances in this disease, we now have 2 agents that have been approved, atezolizumab and durvalumab, with chemotherapy. Chemoimmunotherapy is clearly the new standard of care in patients that present with extensive stage disease. We have a new agent, lubrinectedin, for a second line treatment. Despite these new advances, the outcomes remain dismal for the majority of patients, and we have few long-term survivals. There's still an area of excessive investigation to determine potential new treatments, and I would not be an oncologist without showing you a CT scan. So this is a patient of mine that, as you can see, presented in 2017. With rapid progression after just a few cycles of carboplatin and etoposide, We did nivolumab and ipi because, again, this was what was available in 2017, and you can see that the patient had a marvelous response to this agent, to this combination. This was in 2018, and the patient is still alive now off treatment. So clearly, there is a potential for long-term survivals for some patients. Why is this patient different to the majority of patients that progress? We don't know. And how will we have, how will we translate these results to the majority of patients is something that remains a matter of investigation. So with that, I'll go to Shailander to continue this presentation.
Great, thank you, Rafael. Excellent presentation. So I think we have maybe 2 or 3 minutes for questions. So I see a question from Dr. Amar again. Why is immune therapy less effective in small cell lung cancer, as it is supposed to be an immune-mediated disease?
Well, so, I wish I know the answer for that. I think that, well, we don't know why. Is it because it's just an aggressive disease that immunotherapy needs more time? Is it because there's not an immune infiltration into the tumor? I don't know, and I wish I knew, but I don't know.
Because like melanoma, 70% response rate, and renal cell, it's like, so that's, and this is supposed to be sort of similar kind of thing, so it's a little strange.
I guess, Rafael, do we know about the mutational burden in small cell as compared to non-small cell?
Yeah, so there's been analysis in both mutational burden in the tumor, but as you know, mutational burden in tumor, when you get a sample for this disease for diagnosis, is a very small volume of disease that you get. So many times tumor mutation burden cannot be analyzed. So in the patients, when this has been analyzed, there has not been this has not been a biomarker that correlates with activity of immunotherapy.
Thank you.
I guess my question is for both you and Jack. Lung cancer's an example of cancer where there's the best data, I guess, with chemoimmunotherapy. In the melanoma world, we don't combine immunotherapy with other agents as much. I'm going to present some data on combination with targeted therapy later today. But chemoimmunotherapy, I treat Merkel cell, and chemotherapy works really well. And we talk about combining it over there, and Merkel cell is very analogous to small cell lung cancer. But I always wonder if the addition of chemo is compromising the effectiveness of immunotherapy by suppressing the immune system. But do you have a sense of maybe the immune-related adverse events? I mean, that would be one way to indirectly, allude to whether chemotherapy is suppressing the immune system and possibly compromising the outcomes from immunotherapy.
I'll just add some thoughts, and I doubt that either of us has the definitive answer here. I don't, but my sense is that I'm not convinced at all that there's a positive interaction there may be from antigen release leading to enhanced immune response as well. But what my read of the data is that it's essentially just a superimposition of what you'd get from chemotherapy and what you'd get from immunotherapy, and the benefits that there may be from integrating both early is just that you get 2 shots on goal in the beginning in a disease where whether it's small cell or non-small cell, there's a significant risk of attrition over time. That if a treatment doesn't work, a patient can become worse by the couple of weeks, and then by 6 or 8 weeks in, there's a real chance that a patient is going to have a worse performance status and be in a wheelchair and not be a candidate for chemotherapy if you started on immunotherapy and it guessed wrong and it doesn't work, or less likely that a patient will be too sick to preclude immunotherapy, but you may, it may be that immunotherapy is more constitution dependent, and you need to, if you're in a free fall that and your performance status is going from 2 to 3, you're not as likely to benefit. I haven't seen anything more than just the additive effects, really the superimposition of both the efficacy and the tolerability by giving these drugs first line versus later. And that's why I personally think if I were to know that a patient had a really good chance of responding to immunotherapy alone, say patients, there are data to say that if someone has a 90% or 100% PD-L1, that they have a better chance than someone with PD-L1 expression of 50%. If they didn't have a significant tumor burden, I would favor pembro monotherapy with the thought of sparing them and giving treatment sequentially. But plenty of patients are the opposite. They have a big tumor burden, liver mets, and they have more weight loss and pain every couple of weeks. Those are patients where I wouldn't have confidence that they're going to be able to get to second line in the same condition and would front load.
Yeah, thank you. I think I have the same sense that I don't think chemo is adding synergy to the combination, but yes, you sometimes just need to use it to stabilize the patient, because immunotherapy, what we know is it doesn't work when the disease is explosive.
Right.
And we need to slow down the tempo of the disease. So,
and I think that may be an important part of the timing with small cell too. I mean, if it is just taking off, it's like catching a bullet, and even a therapy that could be effective in other circumstances is not going to get a toehold in time before the cancer overtakes someone.
Great.
So
Thank you.
I agree with that, but Shilanda, your question is a good one. Is whether the chemotherapy is immunosuppressing the patient, and in terms of side effects, I don't know the melanoma literature that as well as you do, but what we see in side effects of immunotherapy, we see a lesser immunotherapy side effects when we add the addition of immunotherapy. So the radar for Nivo or Pembro or whatever PD-L1 agent, the rate is around the 10% side effects. Most of them are treatable. So we don't see a less side effects than when we use immunotherapy alone.
Great. Well, we'll